Most of us know that not every child has equal opportunity to succeed. However, what you might not know is that this disadvantage starts before a child is even born.
When a mother experiences poverty while pregnant, their child is more likely to be born low birth weight due to the intergenerational health effects poverty has while the child is in utero. Let's say we have a mother experiencing poverty while pregnant. She might be facing housing insecurity, lack of proper nutrition, a strain on her income, all of which impact her stress and health and therefore impact her baby. One manifestation of all these health impacts is a low birth weight birth. Being born low birth weight is associated with many adverse outcomes later in a child's life, affecting their educational attainment, emotional development, and more. The main harm here is that poverty, in a hereditary way, thwarts the capabilities and limits the opportunities of children born to mothers experiencing poverty from the moment they are born, before they even have the chance to exercise them.
Currently, about 1 in 12, or about 8% of babies in the United States, is born with low birth weight, which is also known as LBW. The rate of LBW births has increased 22% over the past 3 decades, from 6.8% in 1981 to 8.3% in 2021. Significant and persistent disparities in low birth weight exist, with minority populations and poor mothers being at a far greater risk for these poor birth outcomes. A comparison of black to white births depicts a troubling difference in the rates of low birth weight. LBW is recognized as one of the primary factors contributing to racial and ethnic disparities, as the Black LBW rate has been at least twice the corresponding rate for white mothers for decades, according to the United States Department of Health and Human Services. One of the major factors for disparities in low birth weight is access to prenatal care. Mothers receiving inadequate prenatal care compared with mothers receiving adequate prenatal care are at a greater risk of experiencing LBW births, as prenatal care can help identify health risks and steps that are needed to improve a mother's health prior to giving birth. Research has been done that has found Black mothers who did not initiate prenatal care during the first trimester tripled and nearly doubled the corresponding proportions for white and Latinx mothers. Studies have also found that in all racial and ethnic groups, birth outcomes improve with higher education. One study found that women who did not complete high school had a 9% higher probability of having an LBW child than those who did. It is also observed that mothers with less than 8 years of formal education are 1.5 times more likely to have LBW infants.
Poverty is hard to define. However, the relationship between maternal poverty and LBW exists no matter the level of definitional complexity. We'll start with the most simple definition of poverty as income lowness. A study conducted by Janet Curie and Enrico Moretti found that children born to mothers with a low socioeconomic status were 6% more likely to be born with LBW. There's a generational factor here as well. Mothers with LBW were more than 50% more likely to have children with LBW. Low income affects not only the rates of LBW, but also the financial costs of a hospital birth. The financial costs associated with treating preterm labor and delivery are quite high. The average hospital cost for an LBW infant is estimated to be around $27,000 and $76,000 for a very low birth weight infant. This is quite a big difference from the average cost of $3,000 for a normal weight newborn. While low income is a helpful place to start when discussing how poverty is connected with LBW, there are many other ways that a mother's thwarted capabilities might affect her child's birth weight. This capabilities approach is drawn from the work of Martha Nussbaum, building off economist Amartya Sen. Nussbaum proposes that people ought to have the capability to achieve all the basic needs of humanity if they choose. A life without these capabilities might be described as a life experiencing poverty, a deficit of the dignity essential to a flourishing human life. With this approach to poverty, we can imagine that much more about a mother's life than just her income might affect her and her child's ability to flourish. This is empirically backed. For example, as Jonah mentioned, Timothy Gage and a team of researchers found that even a mother's education levels can affect her child's birth weight, with lower education levels correlating with lower birth weight. It's important to note that these relationships themselves are not causal. For example, a child is not born with lower birth weight because there is some biological difference between a mother who went to college and one who did not. Rather, these correlations indicate that the oppression and poverty a mother experiences can affect her children even from the moment of birth. Martha Nussbaum's capabilities approach is also a helpful lens through which we can examine the harms associated with LBW for children and how it truly is a representation of oppression from birth. The first of these capabilities is life. Nussbaum describes the life capability as being able to live to the end of a human life of normal length, or not dying prematurely. LBW directly affects children's access to life. Gage's team found that infant mortality rates were higher for children born with LBW. Jason Boardman and a team of researchers also found that LBW has a significant negative effect on children's developmental outcomes.
Another capability thwarted by maternal poverty is bodily health, which Nussbaum refers to as the ability to have overall good health. A 2020 study found that housing insecurity, one facet of poverty, impacts maternal mental health, correlating with a 21% increase in the probability of depression and a 19% increase in self reported parenting stress. Depression, anxiety, and stress increase the likelihood of having a low weight baby at birth. Therefore, severe housing insecurity during pregnancy was significantly associated with low birth weight and extended NICU stays. This shows how a child's ability to have good health is hindered by intergenerational poverty as soon as they are born. The ability to have senses, imagination, and thought, as cultivated by an adequate education, is also hindered due to the effects of maternal poverty. Being born with low birth weight is correlated with a loss of a tenth of a year of education on average, according to a study by Curry and Moretti. According to a 2015 study, low birth weight children were 2 to 6 times more likely to have poorer school performance in multiple areas, including science, language, and technology, than their peers born at a standard birth weight. The effects of maternal poverty on children in utero, thwarting their capabilities the moment they are born, highlights the intergenerational and cyclical aspect of poverty. Miranda Fricker also brings to our attention another facet of injustice called epistemic injustice, which is the mistreatment of someone as a knower and communicator. We see this injustice playing out in our topic because there are very limited stories or accounts of women who actually experienced poverty while pregnant and how that affected their child. This could be due to stereotypes of impoverished mothers being irresponsible, which causes medical professionals or the media to dismiss their thoughts, or it could be an act of self-silencing, where mothers perceive that they will be blamed for the outcomes of their children, even though they are caused by poverty, so they choose not to speak. Maternal poverty is caused by a variety of external systemic factors, which we will address in our next project.
So we've talked about how maternal poverty manifests itself in harm for the child as soon as they are born, particularly in being born with a low birth weight. And we've talked about how being born low birth weight can impact a child's capabilities, such as through bodily health and educational attainment issues. But now, we want to focus on what causes this disadvantage by examining the ways in which the mother's actions, while experiencing poverty and while pregnant, are constrained in a way that impacts her child and can lead to being born low birth weight. There are many reasons why babies can be born low birth weight, which mostly occurs when babies are born prematurely. We want to focus on 2 pressing causes that relate to poverty: increased maternal stress or anxiety, and a lack of access to prenatal care. Using individual explanations for why mothers experiencing poverty are more likely to face increased stress or lack of quality of prenatal health care is not enough. In fact, using explanations that blame mothers for choices they made while experiencing both poverty and pregnancy causes us to miss the bigger picture, that there are structures at play which reduce the choice options these mothers have. To examine these structures at play that influence the mother's actions in a comprehensible way, we're going to follow 2 hypothetical stories that are based on real-life experiences. These stories will not cover everyone's experiences, not even close, but they will highlight how social structures constrain a mother's actions in ways that could result in her baby being born low birth weight. As defined by Eastwood and Smith, social structures are long-lasting, individual, connecting aspects of the social environment around us that both enable and constrain the actions of all individuals.
Let's say there's a single mom, Sandy, who is pregnant and experiencing poverty. This is not uncommon. According to the National Women's Law Center, the poverty rate for families headed by single mothers was 31% in 2019, compared to 5% of married couple families. When those single mothers are also people of color, their likelihood to experience poverty is even worse. Those who favor individualistic explanations might say this is due to poor personal choice on the part of the single mother. Choosing to be single sets them up for poverty, or it could cater to the idea that women are inherently weaker mentally, emotionally, and physically, and therefore cannot support themselves or their children alone. But these explanations miss the structures that link poverty and single motherhood together that are outside of mother's personal control. Let's look into some of those. In our example, Sandy used to have a partner, but she left him after he became physically abusive towards her while she was pregnant, which happens to over 320,000 pregnant women per year. Sandy also knew that the combined household income between her and her spouse could cause her to lose 1/3 of her welfare benefits on average. As a single pregnant mother experiencing poverty, Sandy doesn't have the built-in extra support of a spouse, so she is burdened with the stress of being the sole income provider for herself and her child. but she faces difficulty finding employment, like 59% of single parents also reported in 2021, because employers fear her instability as a worker, and being a single parent does not fall under federal anti-discrimination protection. Without a job, Sandy does not have access to health insurance, reducing her ability to receive quality prenatal care, which costs about $2,000 on average without insurance. Sandy is also hesitant to talk to social workers, welfare officials, health officials, or employers about her needs because of the overwhelming fear of being judged or punished due to the stereotype that mothers in poverty are lazy or neglectful, having children just to receive more welfare benefits, or are actively engaging in drugs and prostitution. So, Sandy often lies about the realities of her hardships, especially because telling the truth bears the risk of losing her child to CPS or sacrificing her welfare benefits in the face of constantly changing definitions of eligibility and fraud. As one real-life mother experiencing poverty put it, quote, "It's like you can't tell the truth because you lose everything if you do."
Let's say Jane is a junior in high school. She started feeling nauseated every morning, so her friend told her to take a pregnancy test. It came back positive. Let's back up and think about how Jane might have gotten pregnant as a teen in the first place. Maybe she goes to a school without adequate sex education, or with an abstinence-only program. That wouldn't be unusual. 42.5% of high schoolers still report not receiving formal instruction on birth control methods, according to Columbia School of Public Health. Jane could also be a victim of sexual abuse or assault. According to the Guttmacher Institute, research is inconclusive right now, but indicates that between 15 and 62% of teenage moms have experienced sexual abuse. Not only is Jane pregnant, but she's also experiencing poverty. There are several reasons why this might be the case. Jane's family could be experiencing poverty, which is associated with higher teen pregnancy rates, according to Anna Pinman Aguilar and her team of researchers. Or maybe Jane gets kicked out of her house because she's pregnant. Jane could also be affected by lower labor market opportunities if she doesn't graduate high school. The CDC reports that only 50% of teen moms graduate high school by the age of 22. Here's a good chance to pause and recognize why these problems are structural and not just the result of Jane's individual actions. An individualist might say that Jane drops out of school because she just doesn't have the grit to finish, or she doesn't care about her education enough. While we might object to that explanation even on an individual level, we can back up and see how it ignores the larger causes behind Jane's pregnancy, namely the failure of the school system to teach her about safe sex and the lack of support once she found herself pregnant. Jane's situation isn't simply a product of her choices, though we don't want to diminish her autonomy, but rather is the product of the complex interactions between her action and the constraints placed upon her by the social structures around her. So, how might Jane's situation, constrained through the structures we've been discussing, affect her pregnancy? Well, she could be afraid that she would lose her child. One study by Maureen Heeman and a team of researchers found that some women do not seek prenatal care because they are afraid that Child Protective Services will take their child away. Jane also knows that her family and friends will likely reject her or treat her differently if she acknowledges her pregnancy. For example, one real-life teen mom reported in Teen Vogue that her friends dropped her after they found out she was pregnant. So Jane has a good reason to think this might be the case. The stigma of being a teen mother or fear of parents' responses is a huge reason that teen moms don't seek prenatal care, according to Sally Hughes-Lee and Laurie Grubbs' research.
Linda and Jane's actions would be even more constrained when you consider the structure of race. According to the United Department of Health and Human Services, the low birth weight rate for Black mothers has been at least twice the corresponding rate for white mothers for decades. This huge difference points to the fact that racism and its effects are factors in the health disparities in pregnancy outcomes and babies' health. Reasons why this disparity exists may be that African Americans in the United States have a distrust in the healthcare system. Research done by the American Public Health Association has shown that Blacks are much less likely to report trust in their physicians and hospitals, thus leading them to be less likely to seek treatment and prenatal care. Furthermore, medicine has a history of bias, where there is a stereotype that leads to doctors not believing when Black women are in pain. A 2016 study found that nearly half of first and second year medical students believe that Black people have thicker skin than white people, and perceive Black people as experiencing less pain than white people, an idea born from 19th century experiments that were conducted by a physician named Thomas Hamilton. Race seems to play a role as a structural barrier that leads to Black mothers being at a far higher risk at experiencing low birth weight births than white mothers. It shows that structural explanations for causes of oppression are more important than only examining individual and biological reasons for why inequalities exist between groups.
We've spent time in this series talking about the harms associated with low birth weight and some of the social structures that cause children to be born with LBW. The natural next step is to ask what we ought to do about it. First, we must back up and ask if we actually have an obligation to do something. Is there an injustice occurring here? Or might low birth weight be a tragic but unavoidable failure of individual parents to take care of their children? This is a good time to back up and remember from our last video that while people are individuals with autonomy, there are structures like poverty or racism that affect their ability to make the choices they want to. Sadie and Jane aren't bad moms who don't care about their children. Rather, they are mothers whose choices are constrained by the systems they are a part of. With proper monetary support and prenatal care, their child's birth weight could have been healthy. The prevalence of low birth weight, particularly among those experiencing poverty and those that are a part of communities of color, is preventable and unnecessary. Therefore, we have an obligation to help. But what should be done?
One promising response to the issue of low birth weight is providing a UBI for parents beginning with pregnancy. Giving pregnant mothers a guaranteed income of around $1,000 per month can help improve the mothers' lives. By helping them pay their rent or day-to-day needs like food, a UBI can help take some of the financial burdens for pregnant mothers. Staying healthy during pregnancy can be costly. We believe that a UBI or monthly check can help with those high costs. Additionally, we believe that this recommendation respects mothers' agency, as they are allowed to spend that money on whatever they choose. Trusting them to do what they need to do for themselves and their family felt like a great solution to us. Daniela Gutierrez, a 28-year-old single mother who has been part of a pilot program in New York City, similar to the one we recommend, described the $1,000 per month as life-saving and that the monthly sum has helped make her a better mother. A monthly check will give these mothers an income they can count on and help relieve some of the stress that comes with the great financial expenses of being a mother. Furthermore, a UBI for pregnant mothers has been seen to be a very successful program, as countries like Sweden have one. Sweden leads the world with the smallest LBW rate at 2.4%. In comparison, the US ranks 31st with an 8% LBW rate. All pregnant mothers in Sweden are entitled to free checks during pregnancy. We think a similar policy in the US has a lot of potential, as providing guaranteed income support to mothers during pregnancy is an innovative and equitable approach that will ease some of the financial stress that also often keeps women from being able to put their health first. From part one of our project, we recognize that Black mothers suffer disparate health impacts, in part because of the persistent wealth and income gap. This recommendation takes action to end these disparities and is empowering mothers with the resources they need to have healthy pregnancies and births. Dr. Zia Malawa, the director of the nonprofit Expecting Justice, has helped set up a similar UBI program for women in San Francisco and said, providing direct, unconditional cash aid is a restorative step that not only demonstrates trust in women to make the right choices for themselves and their families, but could also decrease the underlying stress of financial insecurity that may be contributing to the high rates of premature births in these communities.
The funding for a UBI would, in all likelihood, come from higher taxes, especially from wealthy individuals. This is, of course, unfavorable to those whose taxes would increase. That is a real inconvenience to taxpayers, and that burden should not be diminished. Yet, this burden pales in comparison to the burdens experienced by children who have negative health and educational outcomes because of low birth weight, through no fault of their own. When you compare the two's burdens, we can see that although higher taxes are certainly understandably objectionable by the wealthy, no one can reasonably say that we should prioritize a marginal loss of wealth over the life and health of innocent children. Furthermore, it's not as though the taxpayers will only suffer and have no benefit at all. There are many benefits to a world where low birth weight is less prevalent. First, as we've discussed, low birth weight and health complications are expensive, and much of that burden is passed on to the taxpayer through paying for healthcare. There's going to be a monetary burden either way. Doesn't it make sense to pay to prevent suffering for children rather than paying for the effects? Additionally, there's just a general benefit to living in a world with less preventable suffering, whether or not there's a monetary benefit. No solution is without its problems. Many people acknowledge that low birth weight is a problem and want to find a solution, but would reject UBI. There are many objections to UBIs more generally, but the best argument is that lack of money is not the only thing causing and perpetuating poverty in the US. This argument, here outlined by Lelina Estepin, says that within the US, the program is too expensive and not nuanced enough to be effective. However, in the case of LBW specifically, money is a huge factor. Mothers need to be able to afford nutritious food and prenatal visits for the health of their children, and money can help them do that. While there are more complex structural factors behind this issue, as Estepin points out, in this case, money can help mitigate the effects of those structures and cause better health outcomes for children. We don't want to ignore the other factors causing inequity in the US, but money in mothers' hands is the quickest and most effective way to start saving lives.
Another promising response to address the unjust harms of maternal poverty on children are home visiting programs, such as the Nurse Family Partnership. These programs match low-income single parents, usually mothers, with a specifically trained nurse that visits mothers at their homes for 6 months during their pregnancy and throughout the child's second birthday. The Nurse Family Partnership is the widest used nonprofit home visiting program, operating in 40 states and helping over 33,000 families per year. The nurses collaborate with these parents to teach skills in diet, breastfeeding, safety, and more, address mental health burdens, and help apply for other government assistance programs or jobs. The nurses and parents form close relationships to build trust, allowing parents to feel empowered to care for their children themselves, as one recipient mother put it. This partnership helps the mother by building confidence, finding employment, other resources, and alleviating the mental stressors of parenthood. And it also helps their child. One study found that children born to mothers who received home visits were born almost a week later than those who did not, and weighed an average of 7 ounces more at birth. According to one study, participation in the program showed positive effects that lasted more than 12 years after the visits ended, including a significant reduction in behavioral and intellectual challenges for the children, higher achievement in school, and less mental health issues. In sum, home visits improve a child's well-being later in life, helping to break the cycle of poverty and inequity. While this program and others like it are funded by the federal government, advocates have been calling for an increase in funding, saying that only 3% of families in need currently have access to these services. Expanding access to home visit programs would require an increase in funding from the federal and/or state governments, most likely resulting in a tax raise, much like with the UBI program mentioned before. In a similar line of reasoning, while increasing taxes would cause a loss of wealth for individuals, that is certainly a burden, that loss pales in comparison to the loss of autonomy and dignity faced by mothers experiencing poverty and the loss in well-being and emotional and intellectual thriving for children that occurs without these programs. Therefore, from a contractualist standpoint, the taxpayer could not reasonably reject the policy of increasing funding for home visit programs. One main concern with home visiting programs is that they would actually violate the parents' autonomy by forcing their choices or violate their dignity by being overly condescending. While this is definitely a risk, training nurses specifically to form bonds with mothers that establish trust and listen to their voice could reduce this potential effect. Also, nurses provide resources and information to parents, helping to overcome structural barriers of a lack of information or access to medical professionals. They do not make their choices for them. Providing parents with this information enhances their autonomy and dignity by giving them an outlet to express and address their specific concerns and providing them with the resources and information to have more freedom of choice.